Hi, good morning, good afternoon, and good evening. And it's afternoon from Nigeria here. My name is Danjuma Ada. I am president of the World Hepatitis Alliance. I hope you should know that the World Hepatitis Alliance is an international network, a membership-based organization. We're registered in, we have operation office in London, and we have over 300 members across the world and operating in over 100 countries. Nigeria is one of the countries where we have very strong membership base. And the World Hepatitis Alliance is actually having an advocacy and financing project here in Nigeria. So the webinar today is really going to be very interesting. We're looking at understanding the investment case for hepatitis elimination. And to set the ball rolling, I need you to understand that the World Health Organization set global targets for the elimination of viral hepatitis as a public health threat by 2030. The first set of goals were set 2016, and it was reviewed last year with a midterm by 2025, and by 2030, the viral hepatitis should be eliminated as a disease of global public health threat. Now, that is ambitious indeed, because many countries like Nigeria, many countries across Africa signed up to that commitment that they will eliminate hepatitis by 2030. Now, eliminating hepatitis will definitely require investment. And however, it's really unfortunate to say that the current levels of global investment in viral hepatitis elimination programs are insufficient to achieve these goals. And that is why we need to look at, as advocates, as people working in this space, we need to explore what are the innovative ways through which we could push for the elimination of hepatitis. What could we do differently in the context where there are no resources? And that is why we're having this interactive session, and we're indeed honored and happy to have someone who has been in this space, who has driven hepatitis elimination at the local level in Nigeria, to share experience and to tell us ways by which our civil society and patient groups we could do and mobilize resources to ensure the elimination of hepatitis across Nigeria and across the globe. So I would like to welcome everyone, and thank you so much for joining. And first of all, hand over to Jess, who will now introduce, and then we move on with the webinar. Jess from the World Hepatitis Alliance. Thank you.
Great, thank you. Thanks, Danjuma. As you said, really pleased to be with everyone today and be able to have this webinar as part of our Nigeria financing project, looking at advocating for increased resources for hepatitis elimination. I'm very pleased to be joined today by our speaker, Chukwuemeka from the Clinton Health Access Initiative. So the Alliance first started working on financing in Nigeria in 2017, and it was alongside Chukwuemeka and the team at the Clinton Health Access Initiative. So really pleased to have his expertise on the webinar today, and I will hand over to him for his presentation.
Thank you, Jessica. Thank you, Danjuma. Can you confirm that you can hear me?
We can hear you, yes.
Yes, we can hear you. Thank you.
Great. So I'll just put up my presentation and we can go. So let me start by thanking WHO for putting this together. This webinar to really showcase this work that we had done a couple of years ago on the financing project in Nigeria. My name is Chukwuemeka Agwuocha, and I work with CHI, Clinton Health Access Initiative, on hepatitis project. As Danjuma mentioned, we have been at this work for quite a while, trying to see how we could drive access to hepatitis treatments within the region, and taking learnings from the global clients. But then again, it's important that we showcase how we've been able to move the needle forward in the absence of huge donor investments, and how we've been able to think through opportunities for financing within our local context, which in most recent times have turned out to be models that have been explored to drive financing mechanisms across different regions. So we'll just take you through the epidemiology of hepatitis, which I'm sure a lot of you are aware of, and touch on the child hepatitis program. And ask the question, why an investment case for Nigeria? Why should we think of one for Nigeria? That will showcase or share with you the WHO investment case which was done, where we are following those initial outcomes and also discussions. So go to epidemiology. I'm sure a lot of us are aware of this picture, aware of this. Globally, we've seen that the high burden for hepatitis B and C across different continents. But one thing that sticks out here is our Afro region, being Africa, where we've seen a huge burden for hepatitis B and C as well. But this graph shows us more of hepatitis C. But from a country lens, in Nigeria, about 18 million persons are infected within the country. In 2018, we had the National AIDS Indicator and Impact Survey, which was conducted to really understand what the prevalence of hepatitis is in the country, which puts it at 1.1% for hepatitis C and 8.9 for B. But then again, what we have noticed is that we have some regional variations, especially in North Central regions. If you look at the graph on your right, the map of Nigeria, sorry, the map on your right, the map of Nigeria, you would see that two states are outstanding in orange colors, Nasarawa and Taraba, which have been shown to really have a burden higher than the national average for hepatitis C. But we'll delve into Nigeria a lot more further down in the presentation. Just to give you that global picture in terms of progress made as well for hepatitis B and C, what we've seen is 71 million persons who got infected with HCV. And thankfully, with the DAAs being available, there's been increased uptake of treatments. But then we've also seen that there's still a huge gap in terms of, who know their status. Initially, it used to be about 10%, but now we've seen it increase to about 19% as of 2017. We've also seen some progress as well in hepatitis B in terms of bed dose 84% coverage of the hepatitis B vaccine. But where the main gap exists is in the bed dose coverage, which we have seen minimal achievements, only about 10% or less. About 50% or less have really achieved the bed dose coverage, and we still have new infections occurring via vertical transmission. But then the elimination goals is actually to achieve for hepatitis C, 5% reductions in deaths by 2030, and also reduce new infections as well in both populations, in both hepatitis C and HBV. And the goal is to see how do we work towards achieving those goals to reduce viral hepatitis as a public health threat by 2030. So looking at the CHI program, just to say that CHI, our approach is to work with the ministries of health to catalyze hepatitis treatment and also to scale up access to these recurrent treatments within the LMICs. And the models that we have used is to have start first by demonstrating the feasibility of this program in the private sector by expanding access to care, by training the family physicians to be able to provide these services. So where we see not just the gastro providing services, but also to have family physicians, treat uncomplicated cases. And the next step, where we are now, is the smart scale. After demonstrating the feasibility of the public sector programs, we move to the smart scale to expanding access to more facilities, creating a hub and spokes model. And that lays the platform for us to move towards elimination. But one thing that has stuck out across this three-step process is the market shaping work, which is key to driving down cost of diagnostics, cost of treatments for these patients. I'm sure a lot of us in this audience are fully aware that back then, before the DAs were discovered, the treatments were very expensive, going for about $84,000. But with different interventions, which we have seen a key reduction in these prices. The graph you can see shows us the cost of DAs before 2014. These were about $3,000. So for generics, actually, but with increased negotiations, with increased procurement, with volume guarantees, more countries coming on driving elimination programs, and also market shaping to eliminate market barriers in terms of different markers along the value chain from X works to in-country access and also at the facility levels. We're able to drive down this pricing. Just most recently, we saw at the Global Hepatitis Resource Mobilization Conference a pricing agreement of $60 for DAAs for South-Africa for a 3-month regimen, which is now available globally. So these have been a lot of efforts to drive down this pricing and also achieving laying the platform for advocacy for more countries to come on board towards driving hepatitis programs. So CHAI is working across several major countries, 2 in Africa and a couple in Southeast Asia. We see Rwanda and India just driving strong country programs and on the path to elimination, but we've seen other countries like Nigeria, Cambodia, Indonesia, Vietnam, and Myanmar piloting different approaches towards hepatitis interventions. We've seen a PPP model in Myanmar. Vietnam champions health insurance approach to HCV treatment. We've seen Indonesia, where the government is fully government budget is actually driving the interventions in Indonesia. In Nigeria, we just have one small state, Nasarawa, which has committed to HCV elimination, looking at the PLHI report as the first area of focus. We'll dwell on Nigeria and Nasarawa, I think, towards the end of the presentation to really demonstrate how these models we're going to share with you today around financing, around the investment case, around the financing mechanism have been able to ensure obtain that desired government goodwill and commitment needed to drive elimination programs, which is one of the global recommendations around HCV elimination. The story around Rwanda is one that we're well aware of, so I wouldn't dwell on Rwanda so much, but yes, there's a huge progress in Rwanda in terms of HCV elimination. We're also seeing countries like, so outside CHAI countries, Egypt also has been at the forefront of this and also supporting other African countries to work towards HCV elimination. So why do we think of an investment case for Nigeria? Nigeria is a very populous country, having over 200 million persons. And as I mentioned earlier, at the time of the NICE survey, we had about 18 million persons expected to be infected, which we believe must have grown up to 20 million persons as at this time. And then Nigeria, we know, contributes about 30% of the African hepatitis burden, hepatitis B. So what this means is interventions targeted at changing the picture in Nigeria are key to transforming, key results within the African context. So we just touched on a few states where CHAI has been able to lay some of these footprints and to really understand what the landscape looks like. Just as I mentioned earlier, we've seen the North Central region where we have the high burden. We see Nasarawa in a different shade of blue, with Plateau and Taraba and Benue. This has shown a really high burden, but with a reflection on Nasarawa, we see double-digit seropositivity rates. Diagnostic space landscape, what we have at the 13 gene expert platforms, and just a few post-tertiary facilities and also a couple of secondary healthcare facilities as well, with a high state burden. Typically, while we have a high HCV burden, mainly in North Central region, we've seen a high hepatitis B burden across the country, but with lower hepatitis C burden towards the south. And Lagos is one of those states that actually has lower hepatitis C burden in general population, tying to the NICE survey. But it's important to mention that the reason why we're going to understand the diagnostic network was to really identify that opportunity for quick integration of services or programs and also facilitate access to diagnostic treatment and to understand the possibility of secure the evidence to drive government goodwill. But the work we have done in Nasarawa and also Danjuma leading the efforts in Taraba, driving government advocacy has led to other states, exploring opportunities for pockets of interventions. And that's where we've seen states like Cross River, Plateau, and the FCT and Bauchi, driving little pockets of intervention. But then as CHI, we try to work at the national level to provide that coordination. So looking at the Nigerian landscape, it's important that if we're actually going to make progress in Nigeria, it's important to really understand what it takes to achieve HCV elimination. And all this was made successful by the discovery of the direct active antivirals, which I'm sure a lot of us are familiar with. But just to make us appreciate a little bit these DAAs, taking us a bit back to where we used to be and where we are now. They were really game changer, and we're providing that platform for oral medications given within a period of 12 weeks in non-complicated cases, with very brilliant, very impressive cure rate at 95% and low side effects, which made it convenient for family physicians to really administer these treatments without much monitoring, without much laboratory tests to be conducted, and also at very pocket-friendly prices, as opposed to the interferon-based regimen. But then that was not just the end of, having these treatments available wasn't the ultimate game changer. Yes, it was as an entry step, but then again, there were multiple domestic challenges which needed to be overcome to drive this, to drive the intervention. Looking at the screen on to the left, you can see that awareness was one of the major challenges, at program inception. Access to screenings was unavailable. Diagnostic platforms were limited to reach over 60 million infected persons at the time. The cutthroat prices existing for these services, in a Nigerian context, it was going for about $50, which was way above, close to about $100 back then, or more. Also, cost of treatments as well, very expensive. But then again, importantly, healthcare workers were unaware on how to manage this disease, hepatitis C. So we came up with different strategies in terms of policy piece, trying to lay the granular framework, driving the public health model, and also trying access to these services. But one key component, regardless of all these interventions, was financing piece. How do we drive the financing piece? And to achieve the elimination, it's important that countries identify ways to drive financing. And there were three major opportunities or sources: domestic financing sources, or out-of-pocket driven patient payments, or external sources, financing sources. And in each of these buckets, we can see some points, some examples to look at. For domestic financing sources, we had a budget, state government budget lines. We had the insurance mechanisms, the drug recovery fund, the taxes, out-of-pocket patient payments. The way to subsidize it was to think about giving microloans, private health insurance funds. For external opportunities, then we talk about the bank loans, grants, some social bonds. But it's important to also understand the country context to identify which of this is the most sustainable approach to explore. But the important thing is to identify a catalytic mechanism that could lay the ground framework, generate enough evidence to drive interventions. So looking at the Nigerian context and the complicated nature of Nigeria, it was important to identify an investment case, to support advocacy conversations and efforts. So WHO approached CHI back in 2016, 2017 to develop an investment case for HCV elimination with Nigerian context. And, and so CHI had to engage the TWG within to really understand where could be the potential areas of focus and how do we build, an activity-based costing model to really show resources that are needed for HCV elimination, taking learnings and experience from existing programs, which are the HIV, TB, and malaria programs. So just to mention that the important questions which were to ask is, what will it take Nigeria to achieve HCV elimination by 2030? How will Nigeria benefit from eliminating HCV? And then again, how do we mobilize these resources to get this done? And for these questions to be answered, it was important for us to develop, that HCV elimination program, build an investment case, identify opportunities for financing. That was the thinking behind this. And progressing, it was important to, first of all, set targets, define activities, get the unit cost, and also started planning and develop a costing model. But we explored a bottom-up costing framework. Before I go into that, let me just touch on the setting targets. So what did was to identify, looking at the years from 2018 down to 2030, and taking into cognizance some epidemiological factors, the aim was to really understand what would be the treatment targets, yearly to drive towards elimination by 2030, taking into consideration WHO recommendations for elimination as well. So what should be that yearly achievements? So we are on target by 2030. And 3 scenarios are developed, the conservative scenario, the aggressive scenario, and the moderate scenario, just to really understand different costing scenarios. And then activities were defined in 2 key buckets, looking at from a program lens and also from the commodity lens, looking at also calculating costs, the startup costs, and also the recurring cost as well. But it was important that we look at this costing from the ground, and go up and put them in different buckets in terms of, these are fall into professional activities, those are fall into testing and treatment, so that was the bottom up costing framework, which was really explored to really arrive at, the cost to achieve HCV elimination. So let me just share with you, as I mentioned earlier, what the targets were looking like. So as at that time, the country were looking at, there was no clear-cut direction to elimination, but it was important to begin to look at what can be explored. And as I mentioned earlier, there were 3 models: conservative, moderate, and aggressive scenario, to illustrate the cost and clinical implications of scaling up a program. And if you look at the table below, you could see the targets that were set, treatment targets that were set across the 3 scenarios from 2018 to 2030. One thing that comes up clearly is that with the aggressive scenario, you're able to reach more people early, and prevent new cases early. So what is mean overall, you have a lower treatment target because we're able to break the chain of transmission, as opposed to the conservative scenario where you continue to maintain, you start from a lower volume of patients, then you go to higher targets, and before it gets lower. So there will still be ongoing community transmission with that model. We also further we want to understand, if through this model, what does this mean? How are we able to avert new cases of infection, and also reduce progression to end-stage liver disease and avert end-stage liver disease, deaths from end-stage liver diseases? So the graphs you can see on the screen clearly demonstrates this. You see the status quo, and from looking at the conservative scenario, you still have some more new infections, but the aggressive, you have lower new infections. But in summary, the elimination model scenario showed that there's a potential to avert new infections by over 500,000, and then avert deaths by over 80,000 by 2030. Should we have, the financing to drive this process? That we discovered. And then the next piece was to understand what were the cost implications to achieve this. As I mentioned earlier, we explored a bottom-top approach to really understand the cost of the services on the ground, developing the activities required, and working back to strategic area. So you see in 3 buckets, you have a test and treat, you have a prevention, you have a drive the response, and the different costs in different buckets, working through the 3 scenarios. So while we do not see, a huge significant difference, across the 3 scenarios, but the aggressive scenarios seems to be, there are higher costs involved at the early stages, but then again, by the time we progress towards the end, you start to see some cost reductions, and overall, it came with the lowest lowest total cost needed to achieve HCV elimination. And then just to give an example of how we were able to generate this cost, we also wanted to really understand, okay, in a case where patients are not provided access to treatments, what would be, the cost, out-of-pocket cost borne by this patient to manage cases of cirrhosis and liver cancers, working across 4 states where we were at the time doing 3 states where the 4 states where we were working at the time, engaging with the facilities to really understand. So you can see, be able to show you different interventions required by yield costs for hospital visits, different laboratory tests, hospital stay, looking at length of stay in different scenarios to really understand what the cost will be. And to see the summary of the cost on the table on the right, and this shows that it costs a lot to really averagely for a patient who has developed liver cancer to get treated if the patient is able to access care early, else it may just be a sad story. And then we also see that the cost to cost Nigeria over 1 trillion naira, that's about 4.98 USD, which will be spent by out of pocket by patients to manage themselves without any intervention, which is in the long run far higher than the cost of elimination. So the cost of doing nothing is significantly higher than the cost of driving an intervention, which is quite significant. So we looked at also the cost savings. So what would be the cost savings should we drive an elimination program? And what we saw was it's a huge cost saving to really achieve elimination, as you can see on the graph on the table there. So it's important that we think of interventions to achieve elimination rather than stay in the status quo situation. So stakeholders will also engage further to really understand what could be mechanisms to adopt to drive financing, what could be possible ways to look at financing models within the country context, and different approaches were recommended, which I'll just take in three buckets. One was to pursue catalytic financing opportunities in the short term to get the program off the ground. The second was to look at health financing models. The third was to also look at donor opportunities, and these were all explored. The opportunities around the short-term catalytic funding, which has to do with instant donor funds to drive interventions, looking at ways to show evidence by different states, or opportunities for state project lines. But just to say that one thing that we saw is that as it stands now, we've seen states come to the table to share, to invest towards hepatitis. Nasarawa, Lagos, Taraba, they've all had allocations towards hepatitis. We've also seen the Federal Ministry of Health recently allocate 150 million naira to procurement of hepatitis commodities. This was actually one of born of the advocacy conversations to states, the national level, and consistent community voice on the need for investments worldwide hepatitis elimination, born of the national model that we just spoke about. The next piece was to look at health financing mechanisms, and one was around the Basic Healthcare Provision Fund, which is a part of the country's, 1% of the country's considered revenue fund, allocated each year towards primary healthcare centers to cover mainly maternal and child health interventions. But the challenge with this space is the focus was quite narrow and limited, and opportunities for inclusion of private services remained a challenge. So this was not an area where we recorded success for the recommendations. The third piece, and that piece under health financing, was the national and state health insurance mechanisms, which at the time there was discussions around co-payment, but with increased market shaping, reducing the cost of treatments, the available allocation for funding is able to cover 100% for screening, burial, and treatments under the National Health Insurance Act, and the Act as it stands now. The next step is around operationalization of this, and to ensure that states are able to latch on this as well in their insurance schemes. Then the last piece was the need to explore opportunities for donor funding, working with development banks or other donors like the Global Fund or other opportunities to drive these conversations. And we've seen increased coalition of our partners on the global landscape. We've seen WHO, we've seen WHA as well, increased advocacy at global level, and we've seen trend. What this means is in this current funding cycle, countries are now freely including hepatitis services into the funding bucket across different areas: adolescents and child health, reproductive health, the PLHIV component, harm reduction, triple elimination, just different opportunities tailored to countries' needs and stakeholder advocacy conversations. So this has also been a success. So what this means is this: the different models that we have proposed over the years have been game changers for different countries in different climes. But this just shows a summary of all the initial recommendations and the next steps as at then. So I just want to share with you just, I think, 1 or 2 slides left. In the Nigerian context, we did an analysis a couple of years, about 3 years ago, to really understand were there any different areas we want to look at for financing, and it still remained, the Global Fund, other donor opportunities, and also domestic funding. And we had seen countries like Rwanda, Cambodia really access the Global Fund opportunities as well. So this last slide just takes us through Nasarawa experience, how you could use this model to build or to drive elimination conversations and government advocacy. And it's in 3 major steps. One is to demonstrate evidence for impact. I recall that one purpose or one goal of WHA in driving this work in Nigeria is to build capacity of CSOs to be able to advocate for government funding. As important that as you begin to think of these conversations, you need to be equipped and armed with the right tools to drive this conversation. And one is having that evidence for impact. Recall that we had shown you, the high burden of hepatitis in Nigeria and the need for an investment case. And that's one key component. What is the evidence? What is the burden within your region? Are you able to articulate, the numbers of epidemiological data, the numbers of patients coming down with this illness? What is the investment case there? What is the cost to treat this person with this person? What is the counterfactual? What's the status quo? You need to understand that, and then with this tool, you can be an investment case and begin to identify potential champions within the corridors of power, within the government that could have these conversations. You need to also understand those who have a shared vision. You need to also look at opportunities for program collaboration as well within your state context. And that leads to that helps to unlock doors to support funding for HCV elimination. The graph just shows you how this model has been applied. Taking that country learning, domestications in a state like Nasarawa, we've been able to get government commitment with initial focus on the HIV or the PHIV patients, driving screenings, diagnostics, and treatment, and hoping that continue to identify more players in the space to drive discussions around hepatitis support. So we get to the finish line for HCV elimination. I think this is my last slide. So I will just pause here and say thank you. I'm ready to take any questions that we may have. Over.
Great. Thank you so much, Chukwuemeka. While we're waiting, everyone, please do put questions in the Q&A section and we can read them out, or put them in the chat and we can read them out, or we can unmute you so that you can share, so you can ask the question directly. But while we wait, I have a couple of questions. So, when we partnered on this a while, back in 2017, it was just focusing on Hep C. We haven't, the Alliance hasn't done it for Hep B. Has CHAI done any work on an investment case for Hep B in Nigeria?
So for Hep B, CHAI hasn't started. Look at the global direction. I think we're gaining momentum around hepatitis B before we had COVID coming and things were a bit slow. But with triple elimination conversations and things getting back online, there's a plan to look at hepatitis B from that regard, from that lens as well. But for now, nothing. We haven't really taken time to look at what will it take to eliminate hepatitis B. I think it's also because of the way hepatitis B is in terms of long-term treatments and all. But it may be an area for an immediate focus may be looking at, okay, how do we close the tap, as popularly said, and mop the floor? So maybe how do we achieve coverage in the newborns to build towards the generation without hepatitis B? That may be an initial approach, and also looking at long-term TDF medication, or once we have a cure on the horizon, it gives us an opportunity to really eliminate hepatitis B as well and do the cost-effective costing.
Great, and thank you. I think that's right, and I know the Alliance has done a lot of advocacy around PMTCT, and it's great that, because Nigeria does have the birth dose, correct? It's just got a really low coverage.
That's correct. We have the birth dose introduced, but it's just low coverage, and the timely administration as well still remains a challenge.
Great. So we've had a question through from Prince, who says, thank you so much for your presentation. I'd like to know how CHAI can work collaboratively with us at the Hep B Advocacy Initiative in Delta State to help jumpstart elimination efforts by the government.
Okay, so in terms of, CHAI is what we have seen. It's in this space is just that government goodwill and commitment is need to really drive this efforts and conversations, and also having that opportunity for to stretch the program, looking at the funding cliff. But then again, CHAI is willing to support. What just reach out, let us know what you're doing, how you're working, and we can decide to guide further typical support to really identify where you need to engage and how you need to engage preliminarily to generate desired evidence that could set the tone to drive government conversations. So we are willing to work with you. We could just drop my email, shoot me an email after this conversation, then we can begin to see how we can advance these conversations.
Great, thank you. I think CHAI you've really shown great progress in the states that you're partnering with. So I think even just some of those lessons in terms of what's really helped to drive or get the political will in those countries is incredibly useful insight. I had another question for you around pricing, because obviously, you pointed out at the beginning of your presentation, getting the costs down was a driver to increasing access. And I know Chai has recently led the negotiations to reduce the costs of Hep C treatment to $60 and Hep B to about $30 a year. So how can, Nigeria take advantage of that? And I guess, are you already working in the states you are active in with the government to make sure they're accessing this new lower pricing?
Yeah, thanks, Jessica. Just to say, interestingly, Nigeria was actually one of the countries to initially access this pricing ahead of, the for hepatitis C, ahead of the WHO, ahead of the Global Health Organization meeting. That was sometime last year, right from last year, and thanks to the WHO and the president who is on this call, who was able to really, get that conversation going, with demonstrated evidence of a high burden in Nasarawa and Taraba and also other states around the North Central zone. Yes, at pockets, low levels, yes, we've been able to access this pricing in terms of the hepatitis C. We've also started conversations to ensure that this pricing is widespread across the country, working with the national program to make this happen. And for hepatitis B, we started having conversations with the distributors in country to ensure we begin to have these commodities available within the countries at that price. So I think our key focus in this third quarter will just be to see how do we expand this pricing deals. I think the important thing is to have a top-bottom approach at the national level to get the national government involved. If we've been signing maybe MOUs or some documentations to ensure that it's available, and getting the gastros as well to be aware of this pricing. I think increasing that awareness will help to ensure that it's implemented and it's effected within the Nigerian context.
Great. Well, it sounds like that's a clear sort of call to action for all the advocates on the call today to make sure that they're aware of the pricing and that they're sharing that with the key stakeholders in their state so that everyone in Nigeria is able to access the new lower pricing. Danjuma, I saw you put your camera on. You got some question, comment you'd like to make?
Jess, I just want to maybe re-echo what Chukwuemeka said. And Chukwuemeka, thank you so much for the beautiful presentation. And I know how passionate you are driving the hepatitis work. Each time Chukwuemeka and I meet, we just all the time brainstorm, what can we do? What could we really do to get support for Nigeria? Who could we reach out to? What partners? So, and I'm happy he just shared with you just now that Nigeria got that $60 first last year. And what we are now looking at, how do we make this not just Nasarawa project, but for the entire country? And good enough that Beatrice now made the public declaration in Geneva. But what we were even working out with Chukwuemeka and other partners was, how do we make that accessible to every part of Nigeria for the $60 per treatment? And please, just for people to know, $60 for the entire 3 months. It's not $60 per month. $60 for 3 months, which means $20 per month. And that is really awesome. So it's just for us now to take advantage, push advocacy and make a lot of noise and see how do we benefit. How do our patients benefit from this? So, and I'm happy that Chukwuemeka is there. So we just need to put our heads together as advocates across the nation to ensure that we really get to benefit from this. And that's just what I want to say. But I think I want to just reiterate that Nigeria started benefiting from this right from last year, before the declaration in Geneva. Thank you, Jess. That's
great. Thanks, Danjuma. There's been no other questions in the chat. So Danjuma, I just wanted to see if you had any final comments, and Chukwuemeka, if you had any final comments before we close for today.
So maybe I'll just go and let Daniel wrap up. So I'll just say really, I want to just thank WHO for putting this together. And as Emma mentioned, our key goal is to see that we continue to improve access to these treatments and to ensure that, you know, we move to that world where we have a generation free of hepatitis B and C illnesses, complete elimination. And I also want to encourage really our partners in Nigeria to ensure that there's access, there's awareness to the restricted pricing, opportunities for integration exist, and to continue to reach out, you know, should they have any challenges or feel stuck, I mean, to WHO, to CHI, and to see how we continue to work together to improve access. But I'll just say thank you to the CHI team, my colleagues who are also on the call, doing the heavy lifting on the ground, getting things to work, and also thank you to WHO for putting this together. Over.
Thank you. While you were talking, we have had another Prince has put his hand up, so I'm going to allow him to talk because we do have a little bit of time. So Prince, if you unmute yourself, you should be able to speak.
Yes, thank you very much for the opportunity. And I would like to thank Chai and Mr. Chukwuemeka for the presentation. And mine is going to be a passionate appeal, if because we'll be organizing a viral hepatitis summit sometime this month. Okay, my team will be organizing that, and we'll be inviting a couple of guests from the Ministry of Health. Okay, because we really need to push on this advocacy, and that's why we're doing this. So I'm wondering if Chai could come in too to be part of the event. That would really be great. Thank you.
Okay, thank you, Prince. So I'll just leave my email in the chat box. Just feel free to shoot us an email, then we could advance conversations on offline and see how if it's possible to be present.
Great, thanks, Chukwuemeka. We have had one other question from someone, Dr. Gulam Godfrey in Uganda, which is in the chat. And I'm not sure if CHI has a hepatitis program in Uganda, but asking how CHI's presence in Uganda can help hepatitis CSOs take into the funding dynamics for hepatitis C, and how does Uganda get access to the hepatitis C commodities? Chukwuemeka, I don't know if you've got any sort of thoughts on that.
Yeah, thanks, Jessica. I was just thinking in my head. I think CHI has hepatitis B program going in Uganda. And I know, and if I remember correctly, I think there was some support from Egypt to Uganda back then. I don't know if anyone is aware. So, but what I could find out is, I know that our program is not, of course, it's not in the whole of a program regions in Uganda. So maybe what we could do is for, I've just dropped my email, so if the person could just send an email that we could see the clear ask and also understand how robust our work is in Uganda, and see if we could create that linkage and create that support. So
great, thank you. I think, you know, a lot of this is, and if we can, you know, facilitate any sharing of best practice amongst our members, you know, please let us know. We can always share examples of case studies of what's worked well in other places, so that we're, you know, sharing sort of these good practices. Danjuma, do you want to make any final comments? I know we're sort of right on time.
Yeah, thank you, Chukwuemeka. Though I've seen the hands of Prince Okinedu raised.
I think that was an old hand.
Oh, okay. Okay, that's fine. Yeah, so okay, maybe Jess, I'll still come back to you to finally wrap up, but I would like to sincerely say thank you. And our colleagues from Uganda, Dr. Golom, thanks for joining, and a few other partners, thanks indeed for joining. And Kenneth, thanks for joining. And then all of you, all the advocates that have joined, we really appreciate this. And please, it will be important that as advocates, we need to really, really have a coordinated approach towards advocacy. We need to really make noise, get the policymakers. For Nigeria, we have new governments at the federal and at the state levels. So please, it's important that we should push advocacy, make awareness. This month we have the World Hepatitis Day coming up July 28th. So let us make a lot of noise. And we still have another webinar that is going to take place on Thursday. Please keep a date with us on Thursday to join this. And we're happy, if Chukwuemeka is happy to share the slide deck, WHA will definitely look forward to us maybe sharing this with you. So, but thank you so much for this. And we appreciate you all. Chukwuemeka, thank you. And Jess, I hand over to you, maybe for the closing remarks. But thank you all for joining, and do have a nice evening.
Great. Thank you, Danjuma. Thank you so much, Chukwuemeka. That was a really fantastic presentation. And I think really shined a light on the different roles that civil society can play in advocating for greater financing and the work that's already been happening in various states. So I'm going to actually give the last word to my colleague, Justin, who's going to share some details about Thursday's presentation. So Justin, over to you.
Hi, everyone. Hopefully you could see my screen okay. Just let me know if not. But these are the details below. I have also put it in the chat. I'll put the link to the next session in the chat, you can see. But that is going to be this Thursday with Dr. Ruth Adami-Bello. And it's going to be all about overall introduction to hepatitis testing and treatment. As mentioned, the link is also in the chat, so feel free just to click through to that. And we'd really appreciate it and look forward to seeing you all there.
Great. Well, thank you, everyone, and looking forward to hopefully seeing many of you on Thursday.
Thank you. Bye-bye.
Bye, everyone.